is now joining.
Find out now at Ancestry. The game.
In case he's within. Okay, with the hour having reached 10 a.m., I'd like to call to order the CCH Managed Care Committee meeting. Roll call.
And we have two substitute members filling in, Board Chair Garza and Director Kim. I'll go ahead and start with the roll call. Director Harrington is absent. Director Masuda Barnett is absent. Director Staines is absent. Director Kim, present. Board Chair Garza,
Present.
and Chair Lowry.
Present.
You have a quorum.
Thank you. Do we require a motion for remote participation?
We do not have anyone connected remotely at this moment.
Any additions to the agenda?
No, but for the record, Director Harrington is in the room.
Please add Director Harrington to the roll call. Thank you. Any public speakers?
We do not receive any registration.
All right. I'll now entertain a motion to accept the minutes of the Managed Care Committee meeting held on April 17th, 2026.
So moved.
I'll second. Any discussion? All those in favor say aye.
Aye.
Aye. All opposed? In the opinion of the chair, the ayes have it. We will now hear a report from Health Plan Services presented by the following members: Dr. Audrey Tanksley, County Care Chief Medical Officer; Chrissy Torino, Chief Operating Officer, Health Plan Services; Cindy San Miguel, Director of Health Equity, Health Plan Services. The floor is yours.
Thank you so much, and good morning. I'm excited to share this morning some updates, really exciting news.
Participant is now joining.
Our health plan metrics. We'll give an update on the Health Choice Illinois contract implementation, a state legislative wrap-up, give some updates on our implementation for HR1, and then Dr. Tanksley will share our quality results from 2025, both our HEDIS results as well as our member experience results, or CAPS performance and next steps. And then we have Cindy San Miguel, who will share the health equity accreditation that we just submitted, and we'll give an update on our fiscal resilience project. All right, we'll start off with health plan metrics. We increased our membership a little bit in June to 377,000 members, just over 377,000 members. In July, we actually increased another 1,000 members. We're now at 378,000. And our empanelment at ACHN and for ambulatory remained fairly stable. On the next slide.
So these are new members?
So
See.
that's our current membership as of June 10th. So we have an average of about 7,000 to 8,000 new members every month. But we also lose members every month. There's unfortunately, this constant churn with Medicaid. So, but we saw an increase from about 372,000 members in May to 377 in June.
Is there a slide somewhere that shows the gains and losses?
We do have that. On the next slide,
Oh, we can keep it.
we show the retrospective back from July of 2025 through June of 2026. So as you can see, along with the Medicaid managed care market, we saw declines month over month through May, and then saw this increase in June. We're seeing another increase in July. The main drivers of that, of course, are our retention, so our redetermination, whether members are staying with the health plan. We saw a redetermination rate most recently in April. Those statistics are a little bit lagging. So in April, we saw about an 87% rate. And then another key driver is choice. So of those in Cook County who are choosing a health plan, whether or not they choose county care, about 34% chose county care most recently in May. And then we'll overall be able to see what happened from a Medicaid managed care market perspective in the coming months. That's usually about 3 or 4 months lagging from the state data.
Yeah, so we've lost 23,000 members since 2025.
That's correct.
But it means one thing, that they now no longer have coverage, but it also means they're more likely to show up in an emergency.
And it's also possible, some of that, and we saw declines from the end of the public health emergency. So
Right.
There are also some individuals who no longer qualify for Medicaid, who went through the redetermination process and may have insurance through an employer or through the marketplace. But there are likely more individuals who have become uninsured over time.
Chris, I have a question. Are we able to determine the percentage or the number of patients that actually leave county care to go to another plan, and then vice versa? Do we have that specific kind of detail?
We get some data from the other managed care organizations when they leave requesting documentation. So we could bring that to an upcoming managed care committee if that would be helpful.
It certainly would be knowledgeable for, I think, me to know. I don't know about the rest of the board, but what that delta is, what the difference is between what we gain versus what we lose.
Yep, absolutely. Happy to share that.
Thank you.
We also have some information about where they're coming from, which plans they're transitioning from, or if they're transitioning from fee for service. So we're happy to share that.
I mean, is that something that Alex would track through marketing attempts? I'm wondering.
Definitely.
I'm sure you can't answer for her, but I'm wondering if you might know.
We definitely do a very rigorous analysis on an annual basis from a marketing perspective, on also the gains and losses we're seeing across different zip codes that we think about as we're going into our new choice campaign. If that would be helpful to share some of the geographies, we could
I
bring
think
that
it
in.
drills down deeper into the landscape.
Sure.
Competitive analysis.
And Chrissy, this is Alex. Chair Garza, I can add that thanks to our marketing director, Luis Alvaray, we now have a robust spreadsheet where we track year-over-year gains and losses, both from a choice perspective and a churn perspective, and then also our investment in marketing and how that aligns with membership gains.
Yeah, that's perfect. Yeah, and I'm sorry, Alex, I didn't realize you were on. Otherwise, I would have directed that part of the question at you, but thank you.
Of
Yes,
course.
a follow-up question, because we do a lot of marketing. I mean,
Good marketing, too.
I've seen billboards.
Good marketing.
Driving around seeing billboards, like, well, I know who that is. But by the same token, I'm sure that there are times when we increase our marketing. And is there a calendar, and maybe that's later on this, where is there spikes when we actually do a specific campaign and then the number of people that come join goes up?
I'm happy to start and speak to that, and then Alex, feel free to
Sure
chime
thing.
in as well. We do have, we're actually currently in the moment where we do focus groups. So we've been doing focus groups all this week. It's actually our members that provide feedback and select the campaigns going into the new year. And then we do a bit of a push going into the fall through the early spring, and that's really around the month that we have the most members going through their choice date. We generally have about 90,000 members going through choice in the month of January. So that's, kind of leading up to that is when we really do a push from a campaign perspective. Alex, would you like to add?
Nope, that's absolutely right. We usually spend the summer testing some of the new tactics that we want to use in our choice campaign, which typically runs, as Chrissy said, in the fall through the early part of the new year. In the last 2 years, we've stretched our primary campaign out into May to better align with our CAPS survey to make sure that quality messages are top of mind for our members. But our goal is ultimately to be in market for most of the year as budget allows.
Yeah, and so we could actually measure and look at and monitor campaigns. When a campaign, is there a spike in membership, or is it stay consistent across the board? There may be a slide later on where we could look at those trends over time to see what's happening when there is a push.
Absolutely. And we, thanks to Alex and her team, have some really great data associated with our last campaign and some of the metrics coming out of that. So we'd be happy to bring that to the next committee if that would be helpful.
Absolutely.
So Chrissy, a follow-up. What percentage of our CCH patients are currently enrolled in county care, would you say?
So of county care, we have 7% of our county care membership impaneled to ACHN. Of the total patient population, I'd have to take that back with our healthcare leadership.
Okay, and then one other data point that I think would be very helpful. It's been shared with me that over the last maybe 5 or 6 months, we've seen a real decline relative to insurability of our CCH patients, dropping from 14% of the individuals being uninsured to over 20%, maybe even up to 24%. Let's track that number because it will not only affect county care, but it will affect charity care and a lot of other things that are tied to the provision of services that we have. That's important information for us to track.
Absolutely.
Thanks.
Mr. Chair, I just want to follow up on your question. It is a major point of focus for Director or Dr. Makaitis and as we know in his evaluation to really look at how we increase that membership coming from who we serve in the county system to Medicaid. And, we got into that whole discussion with Ellie, and I know it's a major focus that we think we can do better with that.
Thanks, Chair.
Yeah, a point I want to make, and just in terms of membership, high membership is good. Utilization is even better. That's where I see the real problem. Is a lot of people have insurance coverage, but they wait for a problem to see a doctor. And that's something, I don't know if we can do messaging around that, because that's the healthier we can keep people, that lowers our costs both on the front end and the back end. And the costs go up as people get older. So if we could do something in terms of what we're doing to look at that, I think it would be.
Well, I think one area of opportunity that Dr. Makaitis and I have spoken about is just the follow-ups. A patient might come in for an episodic appointment, and then we don't see him again for maybe a year or two. And we know that there's probably some follow-up work that needs to be done, at the very minimum, an annual. Right. So I think there's some better opportunities there to improve on that.
Yeah,
Which is
primary
your
care for a lot of
organization.
people is the emergency room.
Yeah.
That's
Right.
the problem.
And that's the problem. Yeah, that's the challenge.
So we have been working at the plan to do just on this issue, and so we're doing a lot of work around our transitions of care to make sure that individuals are connected, prior to discharge, and that they had that follow-up very early. Additionally, we are doing some efforts in our preventative. We'll talk about this when we kind of get to our HEDIS metrics, but in the preventative care and really trying to emphasize the importance of primary care visits as opposed to using, to your point, Director Harrington, emergency services as that option.
Can I ask a quick question? The table one before current membership, HBIS is like the smallest number, total number of current membership, but then why is it 32% of ACHN?
Yeah, I'm happy to speak to that. So the health benefits for immigrant seniors population, there's no additional enrollment being accepted from Healthcare and Family Services into that population. The program was funded again for the next fiscal year, which we were thrilled to learn of. That being said, Cook County Health has been one of the largest providers of care for this population historically. They were actually auto-assigned into county care, and so we have a very significant empanelment with Cook County Health. Based on past claims history, that's how we do assignment, in addition to member selection.
So 32% of HBIS is utilizing ACHN. Is that how I read it?
They are empaneled to ACHN, so that's who their primary care provider is,
Okay.
assigned to them.
Thank you.
Yes, of course. Good question. All right. Any further questions? Okay. We'll give an update on our managed care market statistics. So we are actually at our high water mark from a market share perspective. Last month, we were at 35% market share. We're now at 35.2% market share. So we've been, staying consistent with the market, but overall gaining more members than several of the other health plans. The only other health plan that has continued to kind of grow over time is Blue Cross Blue Shield, who are at 28.7% of market share. So just over 1 out of every 3 Medicaid members in the county are with county care. On the next slide, as you can see here, and as I mentioned, these metrics are a little bit behind. It goes through April of 2026, but the overall Medicaid managed care market has been declining steadily since the halt of, or after the public health emergency and when folks had to complete redetermination again. On the next slide, we are just above budget. So we were budgeted in June at 360,000 members. As I mentioned, we were at 377,000 members for June. And this is a bit of an eye chart, but wanted to share, and we're very happy to share that for the last 3 months, we have been over 90% of claims paid for our providers within 30 days. This was really a focused effort of our finance team to get claims paid as quickly as possible. And so if you look to kind of the columns to the right of the 31 days and over, those have been declining as we've gone into 2026.
I think that's excellent. It's great work.
I agree, and I saw the interview with Becker's and one of the safety net hospital CEOs where they really paid honor to county care advancing payments. I think it was a 10-day thing when I talked to Dr. Makaitis, and it really allowed for that safety net to make payroll to continue providing services in that community, a community, Director Harrington, that you have an investment in. So I think that speaks volumes to county care. And then there was another MCO that was referenced that hadn't paid them what they were supposed to be paid. I think it was off by $100,000 and some thousand. So all that to say that county care is not just worried about its own services and people that deliver them. It's also the partnerships, like in that example that was published, I think a week and a half ago.
Thank you for those comments. All right, and then on the next slide, now we'll transition over to transformation and growth. We were very happy to learn on June 8th that we were awarded a contract through the Health Choice Illinois RFP process. We submitted our RFP proposal back in November and just heard, and we were awarded with 5 other health plans. There's one new health plan that's joining the market, which is Humana. And on the next slide, it gives us a little bit of a timeline of next steps. So the contracts are going to be for 4.5 years with the potential to extend for 5.5 years. Open enrollment will happen in the fall. We'll also be going through a formal readiness review process with the state of Illinois. We've already begun implementation efforts to ensure that we're ready to go for a January 1 operational start date. And if no further questions, I'll move on to the legislative update. So we wanted to share just some of the high-level items that were included in the Medicaid Omnibus bill. So there's quite a few new covered services. There are also going to be new timelines for gold carding. Providers with 90% approval for prior authorization will be gold carded for the following year. So that's going to go into effect January 1st of 2027. There's also going to be a delay in the 72-hour rule, which mandates 72-hour inpatient stabilization without prior authorization. There's going to be a restriction in downcoding. As I mentioned, the health benefits for immigrant seniors population is continuing to be funded for the upcoming fiscal year, which will have a really important benefit, of course, to those members who benefit from the services, but also to the health system and to county care. And then there were several programs that were included in the Omnibus bill, including families receiving emergency support for hunger, which will provide a one-time $400 emergency payment for those that lose their SNAP coverage, and then also a distressed hospital loan program. And now we'll go in to give an update on our work around HR 1. So I know we've shared at these committees several times some of the upcoming updates to the Medicaid program for our Affordable Care Act adults population, which is just over 97,000 of our members. They will be required to have new mandatory work requirements, which will be a compilation of 80 hours of either work, volunteer, education. They will also be required to complete more frequent redetermination. So as opposed to renewing one time per year, they'll be required to renew every 6 months. On the right, you can see quite a lot of groups will qualify for mandatory exemptions. However, there was an interim final rule that was released on June 1st that limited some of the ability for states to qualify more individuals for medical frailty. On the next slide, we're also planning for this new population of qualified immigrants that are slated to lose their coverage on October 1st of 2026. Those groups are refugees and asylum seekers and victims of domestic violence and trafficking. There are still many groups that will continue to qualify for Medicaid, children 19 and under, pregnant individuals, green card holders living in the US for 5+ years. That being said, of course, it will still be, really challenging for the estimated 10,000 individuals that will lose their benefits come October 1st. They have already received a communication from the state of Illinois, and we're working closely with HFS in partnership to communicate and support those individuals. I already mentioned the changes effective to the Affordable Care Act adults, and if you go to the next slide, I'll share some of the work that we're doing in partnership with Cook County Health. Cook County Health has really been the leader under Dr. Makaitis' leadership in launching the Medicaid Impact Work Group, and County Care has our own implementation in support of our members. Because there are kind of sliding dates phase dates where individuals will have to take action for work requirements and the more frequent redeterminations, we'll be sending, based on when that individual needs to take action, we'll be sending targeted text messages, postcards, as we've done traditionally. We also will continue to have a large presence in the community with redetermination events, which we have throughout the community at least 5 times per week. And then on the kind of the communications front, as I mentioned, we'll be working to communicate to those individuals losing coverage on October 1st. We're finalizing a communications plan in partnership with our wonderful communications team, really for all impacted individuals, our members, providers, community-based organizations. We have worked in partnership with the communications team to develop that microsite, the getmedicaidfacts.org website, and then we've created an FAQ document for community partners, elected officials, and others. We have been working really closely with faith-based partners, as well as a partnership with the Chicago Cook Workforce Partnership. Thanks to Commissioner Lowry and that introduction, we have been attending their events, and they have been attending some of our redetermination events as well. And then we are working through we have a community stakeholder committee that meets on a regular basis, actually led by Cindy San Miguel, who's here in the room. And we've been bringing messages around those changes, as those are a lot of the organizations that are trusted community messengers. And then last but not least, from a data sharing perspective, it's challenging for some organizations to know who has to take action, because only those that fall into the Affordable Care Act adult population will need to take action. So we're ensuring that we have our member portal, provider portal updated to show that information so that providers are able to know not only whether they have to come into compliance with work requirements, but also their redetermination date.
Let me just add, and this touches outreach and partnerships. So to make sure the committee knows that I, along with President Preckwinkle and a cohort from Cook County Health, will be going to DC again in September, and we meet with our friends on the Hill and give voice to the needs of the system. So we've already planned that, and that's coming as well.
Wonderful, thank you. And let us know if there's any information that would be helpful for those conversations.
At this point, Letty is running lead on that, and I'm absolutely confident we'll be ready to roll. But thanks.
Yes. All right, and without further ado, I'll pass it over to Dr. Tanksley to give update on our quality measures.
Good morning again. So I am actually going to start with talking about our NCQA metrics, and we're really excited that we were able to get everything submitted and are now in that waiting phase. We have our upcoming audit that will be at the beginning of August, and so the teams are actively preparing and doing mock audits and getting extremely ready for that. This slide just kind of gives you grounding definitions of what is HEDIS and what is CAPS. As we know, there are two parts to that NCQA, and one is the HEDIS metrics. That is a data set that is used by more than 90% of the health insurance plans across the country. It is developed and updated and maintained by NCQA. Similarly, the CAPS, which is Consumer Assessment of Healthcare Providers and Systems, is a survey that's administered to our members once a year, and that also there are a number of questions from that particular survey that also help to influence the rating that we receive. Next slide. So this is our timeline. As I mentioned, we have already gotten to the end of this timeline, and so all of our HEDIS results have been submitted. Our survey fielding has ended, and those results are finalized and now in the hands of NCQA. Next slide. So I do want to highlight some of the successes. We are very proud of the way that we performed this year. Our maternal child health, which has been a big focus of not only county care, but also the state of Illinois. All of our priority measures have increased, with the largest increase observed amongst our childhood immunization status. So as I mentioned before, really focusing a lot on that preventative health care, and we know immunizations is a way to do that. It also gives us just a little bit of insight into the well child visits, given that those immunizations are given at those visits. Our cancer screening measures continue to perform very well. Our colorectal cancer screening improved by 10 percentage points. We have had a significant investment in our behavioral health initiatives, and we are really excited to see that the fruits of that hard labor have shown favorable, and we have an improvement by 11 percentage points in our follow-up measures for hospitalization. For chronic disease measures, we performed very strongly. Again, we're at a 4-star level. A little bit more challenging to move those measures given the chronicity of them, but we are absolutely focused and putting a lot of effort into how we can best partner with our organization, our provider organization, to make sure that we're moving those along. Additionally, our access to care measures, which I alluded to, our well child visits in the first month of life, also performed very strongly at a 5-star rating. Next slide.
Can I just
Yeah,
ask a quick question?
Of course you can.
I'm always curious about this MCH measures. I hear a lot about child measures, but what do we know about maternal health measures?
Yeah, so we monitor those through our pre and our pre. Goodness, why am I making it say prenatal and postpartum measures? And so we do know that early detection, and so early finding out that someone is pregnant early is more beneficial to the outcomes of the mom. We also have done a lot of work in doulas and making sure that moms have access to those additional providers, so doulas and lactation consultants. Overall, protecting the mom helps protect the baby as well, so we are focused in those areas.
So do you see improvement in maternal?
Yes. In our prenatal early detection, we see improvement, as well as in those postpartum visits, and that's where there are still a few gaps, and so we try to focus our efforts into how do we get moms in more, how do we find out when they're pregnant, and so we've diversified a lot of the ways that they can let us know, right? So not just by their doctor's visits, but there's also, they can go onto their portal and let us know, and there's also incentives that are wrapped around that to encourage.
Thank you.
Is there a slide regarding that, and can we track that relative to infant and maternal mortality?
Debbie, can you go to the next slide? Infant mortality, not so much, but yes, the pre and postnatal we can. Okay, and so you can see here the maternal child health measures that we were mentioning. So to your point, Director Kim, childhood immunizations are the first 2 measures that are listed there, and they are specifically around the children. Additionally, the immunizations for adolescents has increased. You can see our prenatal and postpartum care, the timeliness of determining that prenatal care has increased by 5%, and additionally, the postpartum visit has also increased by 3%. I think that's a great takeaway, though, and we can see how we can dig a bit deeper into infant mortality, but we don't have those metrics in this deck.
Well, yeah, but it would be nice to look at it.
Yeah, definitely. So our cancer screening measures, colorectal cancer increased, as I mentioned, by 10 percentage points. And there's been some focused efforts on outreach and getting fit kits to providers, also mailing those kits to the members themselves. We also focus on breast cancer screening and cervical cancer screening. One of our efforts is a partnership with one of our safety net hospitals, working with their mobile mammography unit to help make sure that providers who have gaps in their member receiving their mammograms can utilize this mammogram van to help close those gaps as well. And we continue to encourage cervical cancer screening.
So for colorectal, are we doing colonoscopy or
So the effort has actually been more around Cologuard and more the DNA-based stool testing. Behavioral health measures, as I mentioned, there's an extremely intensive focus in this area. We did not see a very significant change in our follow-up after ED visits, but after hospitalization, we did have an 11% increase. As I mentioned before, we are doing a lot of work with our transitional care teams to make sure that we are following up and getting member schedules and identifying when they don't meet these metrics and getting them rescheduled for their visits. Additionally, after hospitalization in a mental health institution or SUD facility, our 7-day follow-up there is increased by 5%. And our pharmacotherapy for opioid use disorder, which is a measure that looks at individual stability on MAT, has increased by 1.85%. I will, just kind of call out, I know you can see there was no significant change in the ED metrics and a slight decrease in the follow-up in the ED metrics. Some of that, there is focused effort there. Some of that is due to some loss of staff that was actually performing those tasks. And so we are working very diligently to try and replace those staff members and to utilize other staff members in that effort. Yes, Director.
Yeah, do you know what the size of this population is?
What size of the population?
Right, you're talking specifically about behavioral health, and we cover over 300,000 people.
Yeah.
So I'm wondering who's utilizing these services, just in terms of the aggregate number, the areas of the county that have a higher incidence. Is there a way to drill down and look at what's happening relative to this? So I have a better
Absolutely.
understanding.
So you're asking, let me just make sure that I'm understanding your question. So you're asking what percentage of our population has behavioral health needs?
Over 300,000.
Correct. What percentage of that population has behavioral health needs?
Right.
Okay. We can definitely get that for
how things
you.
are trending, and we're doing things to address it, but it'd be good to look at it from the standpoint of the people we're actually seeing, if there's any change over time. So it's not something we can look at right now, but something that would be interesting to look at and
Absolutely.
helpful.
Sure. We can make sure to have that for you.
I have a question. How do we do with depression remission rates after the first year?
Yeah. So we haven't, I actually don't have our depression remission rates, but we are in the process of developing a condition management program specifically for depression.
Yeah.
And that is one of the metrics that we will be looking at.
Thank you. When is that? When do you think you'll have that implemented?
So it is actually a part of our new contract, and so we'll have it implemented for January 1.
Got it. Thank you.
Yeah. On our chronic disease measures, as you can see, we've been performing pretty strongly in this area overall, and we continue to maintain that. We are focused, as with some of our additional condition management that we're developing, we are focused on our chronic disease metrics such as hypertension and diabetes and chronic kidney disease. And so we expect that while these metrics are strongly performing now, our goal is to move them to the 5-star if they're not already there and maintain. Access to care is another metric. Improvement was observed in this and most of our priority access to care metrics. Adult access to care, which is getting that annual appointment, increased by 1.27%. And additionally, our well child visits in the first 15 months of life is where we're really focusing our efforts, given the lower performance in that area. But we do see that children in the later half of that first 30 months of life do attend, and there was a slight increase there. But our efforts, as I mentioned now, are really around those early encounters in the first 15 months of life. Next slide. So here are a few of the initiatives that we're working on to improve our HEDIS scores. So we do have some provider and pharmacy improvements. We are doing a lot of collaboration with the pharmacy around our medication-assisted therapy metrics. And additionally around, we did a project with them that really helped us to get additional data from our PBM partner regarding some of the vaccines, so like influenza and things that people may not receive in their clinic, but they get at the pharmacy. And so we were able to get that data in. Additionally, we were able to get things like, TDAPs and other things that had gone back a significant number of years. So we went back 10 years to actually gather a lot of the data, and it helped to improve and fill a lot of gaps that we were not seeing from our data capture with our providers. Our member outreach and community engagement continues. As Chrissy mentioned, we do our redetermination events and make sure that care gaps are being addressed in those. As far as data and quality goes, we're really utilizing the insights that we're getting from our groups and our surveys, but also increasing our data capture and our ability to get some of our provider groups connected to higher data sources. Our program and benefits are very strong. We continue to promote our incentives and offer Cologuard kits and things like that to our members so that they have access in the community as well. Next slide. I'm going to move on to CAP, which is our survey results. And so the survey is broken down into the adult survey as well as the children's survey. In our adult survey, we saw an increase in all of the categories among the adult population. A few of the metrics from that survey actually are utilized for our plan rating. And so getting needed care, customer service, and rating of specialists are three that we saw significant improvements in. We also had our highest percentiles in the rating of our health plan, as well as our lowest in getting care quickly and getting needed care. And so those are areas that we'd like to focus on during this calendar year as well as the future.
What constitutes getting needed care? What category of services is that?
Getting needed care. So it's a survey. So it's kind of from the perception of the individual taking the survey.
It's not services. Their perception of care or their actual care. That's what I'm trying to understand.
Yeah. So it's an individual taking a survey, and so they're getting needed care could mean a number of things. When I had an emergency, I needed care and I wasn't able to get it at that moment. As Chrissy mentioned, we're in the process of doing focus groups. And so some of the comments that have come from our members during those focus groups around that particular question have been things like dental procedures that they were wanting to get at that time and were not able to get, or timeliness of appointments in their primary care office, so wanting an appointment within a few days and maybe having to wait a few weeks or up to a month. And so it's really, the individual taking the survey, what their experience has been and how they rate that needed care in their mind. There's not a specific
and what do we do with have the results been reported, or have we seen the results based upon this?
So we'll go through the results, but yes, the survey has ended and they have been, and we utilize the feedback from the members during those focus groups to help us identify where we should. So for example, like with the dental, we've heard a number of times from our members about dental and vision care. And so we actually have an active dental vision RFP so that we can make sure that our members are getting that access and getting what they need.
And can I just add one item, which is there's 5 measures. So it's the getting needed care, getting care quickly, rating of healthcare, rating of personal doctor, and rating of health plan that go towards our STARS ratings. So on June 15th, we submitted our CAPS results to the state, and then we also submit them to NCQA. We are benchmarked across all other health plans that have accreditation with NCQA as well. So that those 5 kind of core measures go into our NCQA rating, which last year, and kind of one of the core measures we really look at, which I know it's very high level, but rating of a health plan, it's kind of the measure of like, what is what are the members' overall satisfaction with county care? And last year we received 5 stars, and we saw an increase in that percentage this year. So we anticipate receiving 5 stars, but the benchmarks haven't yet come out, and they will come out later this summer.
So what is the survey response rate, roughly?
Yeah. Can you go to the next slide for me, Deb? Thank you. So our response rate for this year.
I swear I didn't know that was.
No worries. Great question. So for 2026, our response rate was 13.5%, slightly decreased from 2025, but pretty consistent with where we've been in the years prior. And we do oversample the population so that we can achieve that response rate. And so you can see we sent out 2,700 and about 13.5% for the adult survey. For the child survey, there was a pretty steady with last year, 14% response rate in that. And as you can see, we oversampled that population as well too.
What's considered the gold standard for this type of survey, would you say? 20%, or are we nearing it, or where are we?
We actually are above the above the benchmark with 13.5%.
Thank you.
It's impressive that you had the children at such a high engagement rate to respond. I mean, it rivals the adult survey response rate. So expect that.
Next slide. So this is these are the results of the CAP survey. And as you can see, there was, pretty, not market, but pretty good improvement and or stable results from our previous years. We had targets based on 66th percentile of the Press Ganey Book of Business. And as Chrissy mentioned, later this summer, we'll have the benchmarks from NCQA. The Getting Needed Care, which is at, our target was 84.7%. We performed at 84.2%. Getting Care Quickly at 82.7%. Rating of the healthcare at 63.2%. The rating of a personal doctor at 72.8%. And rating of health plan at 73.1% are all of the, those are the 5 that are included in our actual rating. And all of them for our plan have increased. And so we're really excited to know that we're improving in those areas. The next slide shows our child CAP survey. And again, there was a pretty standard responses, not too many significant changes in this one. We did see some improvement in our rating of the health plan in this population. Additionally, saw some improvement in our rating of personal doctor in this area and the rating of healthcare. We are working on the areas to understand better where we can improve in the things like communication and getting, coordination of care. Next slide. So our next steps, we will continue to focus on access to care. We also we're doing that in a number of different ways, really making sure that our population is educated about the benefits that they have available to them. We're working with our larger value-based contracts to make sure that care gaps are delivered and that individuals have additional options, including in-home options. As I mentioned, our dental vision RFP is active, and that is as a response to what our members are saying about the services that they're receiving. And we continuously improve and work to improve our provider directory. We do plan to continue our work in increasing our brand awareness and our reputation. Again, that plays a huge role in our choice rate. And so we do want to make sure that our name and our brand is recognized across Cook County. I believe that's it, yes. And I'll, if there are any additional questions, I'm happy to take them now. Thank you. I am going to switch seats with my colleague here.
Thank you.
Hi, good morning.
Good morning.
As mentioned, my name is Cindy San Miguel. I use she, her, ella pronouns, and I'm the Director of Health Equity. I wanted to give you all a brief update on our health equity accreditation work. So this slide is just meant to orient you to what is part of this accreditation. It's part of NCQA, and it really does provide healthcare organizations and health plans a framework to be, and really a roadmap to achieve health equity goals. To be clear, a lot of the work that's represented in this accreditation has already been part of our workflows and obviously a part of our priorities. So this has really given us an opportunity to really codify and formalize a lot of this work, and then help us understand, are there gaps where we can further drive health equity at County Care? This gives you a sense of the timeline. As mentioned, a lot of this work was already happening way before 2025, but in September of 2025, we did formally apply for the health equity accreditation. The look back period for this accreditation was from December 2025 to June 2026. We're very happy to share that we submitted all of our materials to NCQA around June 26th, and we're looking to have our decision from NCQA by the end of the month. So there's lots of different components. This is a very complex work plan that we've integrated as part of this accreditation, but these are some of the key components. We've done a lot of work around race, ethnicity, language, gender identity, and sexual orientation data collection. We've also reviewed our workflows for access and availability of language services. We've also looked at our provider network to see how we were doing in terms of cultural responsiveness. We did present previously the Culture and Linguistically Appropriate Services Program description to the Quality Committee. So you may have seen that in the past, but we'll give you a high-level overview again. And then all of this kind of culminates to, okay, so what? You know, what are you doing to reduce these healthcare disparities? So we'll give you a little bit of an overview of how that's manifested at County Care.
Quick question. When you look at practitioner network cultural responsiveness, are we really talking about provider diversity?
That's part of it.
Okay.
Yeah, and I can speak a little bit too of like what have been the challenges, which is one, do you have provider race and ethnicity data, which historically we haven't. And so we did kind of use this accreditation as an opportunity to say, we know the diversity of our membership, but we need to know the diversity of our provider network. So we worked with IMHIP to add those elements into the provider directory, so that way now we can begin to ingest those data. So again, this kind of shows how the accreditation was really kind of the foundation to push us for that advocacy.
Thank you.
So the provider network, and you're talking about just race and ethnicity?
That's one element. There's lots of data elements within the provider directory. And I apologize, I'm going to correct the word, the provider roster. So the provider roster is what a provider submits, just saying, hey, this is all of the information that we have available to you. And then some of those elements get integrated into our directory. And so historically in the roster, providers have not had to share their race or ethnicity. And so through some advocacy from County Care and collaborations with IMHIP, it will now be an optional element in that roster.
And I'll just add another kind of key component was around languages spoken by providers as well. So that's another area that we track in a report that we submitted as part of our accreditation. Because as we know, all members have access to interpretation services, but it can be an improved experience for the member to receive care in their primary language.
Yeah, I guess what I'm thinking about is the fact that that doesn't indicate competency, ability, personality. And so you might know somebody that wants to see a Black female doctor, that sees a Black female doctor, but may not be the nicest or the best Black female doctor. So I'm not sure what value ultimately it has. It might make people comfortable, but it may not change anything in terms of the care they get.
Yeah, and that's fair. And it won't be, I know we're getting a little bit into the weeds, but that won't necessarily be in our provider directory. It will only be if a member calls in and specifically requests that information. So we did look into some of the evidence on like racial concordance between provider and member. And so it is a preference. And we thought just, again, for the time being, once those data start to come our way, it would be on a kind of per requested basis. But we still don't have the data just yet.
There may be, when we do that, there may need to be a caveat that we can't attest to any of those things based upon their choice. I don't want them feeling bad because we gave them a choice of a doctor that seems to be the same race as they are or ethnicity, but we can't vouch for the doctor in terms of what the doctor's demeanor will be, what the doctor will be like, what the visit will be like. But we can accept their feedback based upon those experiences, and that feedback would be helpful for us.
Thank you.
So thinking about healthcare disparities, you know, the main thing that I think about is access, right? So, I mean, you could think about provider characteristics in, you know, language and things, but like, is there a way you could actually think about where they are located so actual access to providers can be also, you know, counted in this health equity component?
Sure. So we do kind of independently, and that's just part of our contract. We do both access and availability surveys, and then we also do kind of regular geolocations. There are requirements as far as kind of time and distance to providers within our contract, and we are regularly audited on that and provide that information to the state. And then we also contract with a group that actually does kind of secret shopper to see when appointments are available. And our team does a series of those as well, so that at an individual provider basis, where they, you know, we have them on our, we're contracted with them, we received a roster and all of their data, they're loading in our provider directory, so somebody chooses them, but then they call and they can't get an appointment, so that we can actually have our provider relations team reach out and work with them from an access and availability perspective. So completely agree that there are kind of these multiple components of, like we were talking about, kind of member preference, you know, language access, but then also just having kind of access and availability within our members, like within kind of nearby the member's home. And in alignment with the HFS requirements, we've been 100% across all specialties and primary care as well. So we do look at that on an ongoing basis, but it's a great question and call out.
Thank you, Chrissy. So in the next slide, you'll start to get some highlights of this work. As mentioned, this first bucket of work has really been around data collection, both the quality and the quantity of the data. There was an extensive project called the Member Demographic Project, where we ingested multiple sources of data to improve the quality of the member data and also the quantity. So as Chrissy mentioned, we were able to get much better insights in the languages that our members both speak and the languages that they write in. But we're also now able to see more closely what is their ethnicity, what is their race, and there's a number of different gender and gender identity data components that we gather as well. All of this helps us understand, you know, who comprises our membership. In the next slide, we'll then get into access and availability of languages services. We established workflows and policies related to language services, both interpretation and availability of translated materials. And when we talk about languages services, we're not just talking about non-English speaking members, also members that have disabilities that may impair their ability to hear or to also see. So we have to be cognizant of how we're supporting those members as well. We enhance the trainings that we provide to our provider network, and we also published this provider notice. We did leverage some of the resources from Commissioner Marita. She hosts the Language Access Summit, and so some of the resources that were produced out of that training are integrated into our provider notice and into our training materials. Then we started having a wonderful conversation on what we're doing in terms of cultural responsiveness to our provider network. As mentioned, there's a lot that goes into this. So we're looking at the languages that are spoken by our providers. We're also looking at accessibility by site. So does this particular location have ADA accessibility, and what does that look like? We already spoke at length about the advocacy that we did with IAMHIP to gather race and ethnicity data from our providers and network, and the trainings that we provide to our provider network.
So why do you call that cultural responsiveness? Isn't that more like access responsiveness?
Well, I think some of this is, that's a really good question that I've pondered. A lot of like, what do we mean by culture, right? And so we have these proxies for culture that, from the perspective of this particular element is we're looking at race, we're looking at ethnicity, we're looking at the number of providers that have taken a culture responsive training. We're also looking at the languages spoken by providers. So it's hard to quantify and just say, what do we, what's the culture of this particular member? So these are the kind of the proxy data elements that we use to best understand the cultural needs of our members.
It would be helpful, and you may want to reflect on this and looking at the data. Maybe there's some way to glean out some definition of what culture means, because it's a very broad term. But there may be a way to actually look at the data that you have that explains what we're looking at, implies what culture is based on the data.
Then on our next slide, you all have probably seen some version of this. As mentioned, we presented our Culture and Linguistically Appropriate Services program in the Quality Committee. This is, I kind of describe this as like the Russian nesting dolls, where it's lots of objectives and goals within this kind of larger accreditation. There's 33 objectives and 5 measurable goals. And so we try to make this a little digestible, but there's a lot of activity in this program related to workforce development, the trainings we offer our staff, how do we gather grievances related to discrimination. We're also being considerate of the social determinants of health, and how do we meet our members' needs related to housing, food access, and language access. And then we've also considered what are special populations that we should really be tracking, including our justice-involved members and our populations within maternal and child health.
Yep, and these are subpopulation. There's the hearing impaired and the blind or visually handicapped. Do we look at that?
Mm-hmm. Yeah, and that's definitely, I mean, I think some of those accessibility and activities for that particular population are reflected in our language access and how we're looking at our provider network, particularly by site. They're not specifically called out as special population, but I think that's a really good call out that we can prioritize in the update of the class PD.
So can I just, I don't want to annoy you, but like I am like reacting to this culturally appropriate service, and then you have housing, food access, and like transportation, whatever these social determinants, as if that's their culture. If you lack food or housing, you can't consider that as a part of culture of a subpopulation.
Yeah, I think that's a fair call out. And I think really what the class program description, it's not necessarily calling your housing status your culture, but it's saying that, how is it that we're meeting the diverse needs of the membership?
I know what you mean, but it just makes me wonder about like, why do you actually give that sort of, a vibe, like you can't determine a subpopulation's culture as needs,
Mm-hmm. Yeah, and one of the, per the accreditation, we're following the class standards put forth by HHS, and that really is kind of the way that we've chosen to organize and how the accreditation is asking us to kind of really identify what are the needs of the population, how to respond to them. So I hear you that we don't want to be, I guess, deficit focused and kind of reductive in that way. We're balancing that with the responsiveness and trying to understand what our members need, and to the best of our ability, provide wraparound supports that go beyond traditional healthcare services.
Yeah, if I understand, and basically you're talking about the social determinants of health, that where people live and their zip code has a bearing on their health moving forward. So regardless of culture or anything else, people are going to be challenged in that neighborhood, and there may be a subpopulation in that neighborhood that's additionally challenged based upon culture, race, and ethnicity.
I appreciate those insights and that feedback, because I think there is an opportunity to make some enhancements to kind of clarify what do we mean and ensure that we're not being reductive in that way as we put forth these plans.
Culture is thought science in some respect. How do you measure it on a scale?
Well, primarily you're trying to follow, you're following the guidance, the accreditation guidance. So that's already been defined. And then where you can use subjectivity around
Right.
specifics
And
with the
nuance.
culture, you're doing that in a sensitive way. Right, that's how I'm interpreting it.
I understand, yeah. Thank you. Yeah, and as Cindy mentioned, we're using kind of an existing framework from HHS, and some of this is, you know, kind of the work and support that you provide to members, you know, based on their specific needs at kind of a member level.
So I remember last time I asked a question about how you determine these two special population groups. I wanted to know that too is determined already and given to you, or you actually look at our people, you know, based on their needs to pick the population.
Yeah, I can give a concrete example. I happened to meet Mari Gallagher. She's the one that did the seminal study on food deserts and coined the term food desert. She was in Chicago. And so a lot of people know that some communities have limited access to not food, but healthy food. And we also know that if you have limited access to that food, you're less likely to eat the food. So that gets to be one of what they call one of the social determinants of health. You know, it's what you have access to in terms of housing, what you have access to in terms of food, and what you may have as language barriers. I also know that people that are blind have real challenges. You can talk about sending, you know, material to them, but they can't see the material. So how do you deal with populations like that, or the hearing impaired that have challenges with hearing? So I think that we're talking really about a lot of things, but they're different populations that have unique challenges based upon their race and ethnicity and based upon where they live. And that's the bigger challenge.
Absolutely. And as mentioned the last time we presented this at the Quality Committee, we've gone through several presentations with our community partners, both from our Community Stakeholder Committee and our Enrollee Advisory Committee. And so, Director Kim, as you mentioned, the last time we spoke about this and you asked the question, is some of the priorities bubbled up based on what they've asked us to prioritize. And so there was kind of this, I think, continuous effort to want to focus on our maternal child health populations, and some of the goals are specifically focused around that, and that also is inclusive of our JI, our Justice Involved members as well.
Maternal and child health is also a primary priority of healthcare and family services. So just wanted to state that as well. And then given our partnership with CIRMAC and just the ability for us to work closely and, you know, have historically had a team member within the jail to be able to support folks with Medicaid enrollment and other services post-release. That's a kind of another reason for that being a core population.
And there's also the juvenile detention center,
Mm-hmm.
incarcerated youth.
Yep, of course.
And this really, I mean, somewhat culminates in what you see in the next slide, is really what are we doing to address this? So we're looking at all this data, we're identifying activities so that we can, you know, meet the needs of our membership. But in the next slide, you'll also be able to see how we're looking at this from healthcare disparities. So you heard Dr. Tanksley share a number of different metrics related to HEDIS. This healthcare disparities report provides us a framework to really standardize how we're looking at disparities from a number of different elements, from race, ethnicity, and language, and gender as well. And so again, just to stress, this isn't new. It's not that we just started. We've been looking at this by these demographic elements for many, many years. It's just kind of further encouraging us to unpack that. So as you heard, we've increased the colorectal cancer screening rate by several percentage points. I think it was over 10%, but we're still wanting to ensure that we're closing any disparities between our Black members and our white members. And so this is an example of one of the goals that bubbled up out of this report, is to close that gap to be less than 5 percentage points as a start. And you kind of can see some of the rationale there. We know that this is a large denominator that has high mortality impact, and that we have an opportunity to ensure that all of our members have equal access to care. So in the next slide, it's really kind of speaking to our next steps. We completed the administrative process to package all of our evidence and submit it to NCQA. We're continuing to socialize and operationalize a lot of these activities across all of the health plan functional areas. And, you know, as you all heard as well, we have this new contract with HFS, which is very exciting. And there's a continued prioritization of health equity. So we're ensuring that all of the activities as part of this accreditation align with the health equity expectations from HFS.
And before we move on to the next item, I just wanted to thank Cindy San Miguel so much for her leadership. This is, as she mentioned, the first time that we're going through the health equity accreditation process, and really a huge thanks to our other team members that have really focused on this over the past many months. We've been working to submit, and we submitted our health equity accreditation while also working through and submitting our health plan accreditation, our 3-year reaccreditation, as well as a new LTSS distinction. So just a huge thank you to Cindy and the rest of our team.
Thank you. Cynthia, are there other plans that are accredited for this health equity?
All of the other Medicaid health plans in the state have this accreditation.
Oh, they do? Okay.
And it is a contractual requirement
Yep.
in the new contract. So
It is, okay. Yeah, good. Thanks.
Great. All right. So I think we just have one more topic. Fiscal resilience has been a primary focus this year. We started implementing a new project back in December of 2025 at the start of the fiscal year with the goal of consistently becoming a plan that achieves 25 to 50 million profit margin over the next several years. For County Care, this is to really right-size the health plan and gain sustainability so that we continue to provide innovative programs, support of our members and initiatives, and then also position ourselves to sustain the health system and allow for greater impact. On the next slide, I know that this is a very high-level slide, but our teams have been working across all areas of the organization, operations, finance, and clinical services. So far, we've implemented and estimated just over 69 million in initiatives. These, again, these are annualized, and also they won't all be realized within this fiscal year. That being said, we've kind of set this lofty goal of, and we believe we will hit it, of achieving $100 million in savings over the next year. This is a combination of vendor contract renegotiations, pharmacy optimization with implementing biosimilars, reducing interest. As I mentioned, we have come to paying our providers within 30 days, so that interest reduction, and really looking across all areas of the health plan to improve optimization and reduce costs. So a lot of this work has really come from the innovation and support of our teams across the plan, and we'll continue to share kind of the results of this within Finance Committee. I know that's where we kind of get really into the weeds of all of the different initiatives in play, but wanted to share our progress for the record. And I believe that is my last slide. Any questions or other comments?
Directors, any questions, comments?
No comments, just an excellent report.
Yeah,
Get a
thank
great sense of where we're at and where we're going.
It's very thorough and very informative. Thanks to each of you. Thank you very much. Thank you. Okay. Our next meeting will be Managed Care Committee meeting will be held on Friday, October 16th, 2026 at 10 a.m. My birthday is October 21st. Gifts will be accepted. With that, we have no further business today. And Director Harrington moves adjournment. I second it. All in favor say aye. All opposed, we adjourn. Have a great weekend.
Thank you.
Thank you, Director.
No problem.